Hello, everybody. My name is Mohammed Farouk. I'm board certified psychiatrist, and I also have a PhD in neuroscience from Uppsala University, Sweden. Today's topic is buprenorphine. Buprenorphine is the medication to treat opioid use disorder. In October 2002, the Food and Drug Administration approved two buprenorphine products, Suboxone and Subutex. Methadone has been used to treat opioid use disorder since 1947. Many studies support methadone's effectiveness at reducing opioid use. However, currently, methadone can only be prescribed for opioid use disorder at methadone clinics. That kind of limit its availability. Patient has to go to the methadone clinic to get their dose. On the other hand, buprenorphine can be prescribed in outpatient clinic settings. There are three different kind of formulations currently are available uh, for buprenorphine products. They are for sublingual route, uh, injectable route, and implantable. Generic buprenorphine, naloxone, sublingual tablets, buprenorphine sublingual tablets, buprenorphine slash naloxone sublingual film, buprenorphine naloxone sublingual tablets, Zubsolv, mm, buprenorphine naloxone buccal films, buprenorphine implants, which is for 6 months, buprenorphine extended release injection, which is for 1 month. So, which formulation is better, sublingual or long-acting formulations? I personally prefer sublingual formulations since I can better control them. If patient need to be get off from sublingual formulations for some reason, for example, they have a surgery or they have a side effect or reaction or whatever, I can take them off from the medication and they can be switched to another painkiller, and most likely the effects will be gone within 1, 2, 3 days. On the other hand, with long-acting formulations, my main concern is always that if there is a reaction to drug or patient is in an accident, then reversal of the drug effect will be very difficult. And after an accident, patient may need immediate surgery, and during surgical procedure or post-operative period, they may need high doses of painkillers. However, buprenorphine presence in the body in a long-acting formulation may interact with painkillers, and probably higher doses of painkillers will be needed. So for these reasons, and especially like implantable is for 6 months, even though we can take out the implant if we need to, and injectable is for 1 month, I don't feel that much comfortable with these kind of products, considering accidents happen and side effects also can happen. Methadone and buprenorphine are equally effective at reducing opioid use. However, considering that methadone can only be prescribed at designated treatment centers limits its use. Both methadone and buprenorphine are useful in treating chronic pain as well. Half-life of buprenorphine is around 35 hours and methadone is 59 hours. That's why these medications can be used for treatment of opiate addiction. As a general rule, if medication has a shorter half-life, they are more having a more addictive potential, such as oxycontin, oxycodone, hydrocodone, hydromorphine. They will have more addictive potential, but longer medication with the longer half-life have less addictive potential, and they can also be used to treat opioid addiction. Initiating treatment. Wait at least 24 to 48 hours after last dose of opiate. Wait at least 48 to 72 hours after last dose of methadone, since methadone has a longer half-life. Physician must make sure that patient is in withdrawal. If patient is not in full withdrawal, he can experience worsening of withdrawal symptoms. Withdrawal symptoms: running nose, watery eyes, fever, vomiting, nausea, sweating, chills, muscle aches, diarrhea, agitation, increased blood pressure, disorientation, sleep problem, depression, anxiety, headaches, and cold, clammy hands. So, so if a patient is in opiate withdrawal, they have extremely cold, like ice cold hands, and if you shake hand, uh, they are like icy cold. And this is one of the conditions where you can diagnose them uh, that they are in withdrawal or have an opiate addiction and now are in a withdrawal by just shaking hand. How long buprenorphine should be taken? Um, Once patient is on stable dose, she should start making effort to reduce the amount. There are few people who will take medication for a few months and then can taper off. Majority will need several months to years to start tapering off. There will be some people, especially with chronic pains, who may need this for the rest of their life. So one size won't fit all. Taper schedule. There are no hard and fast rules for taper from buprenorphine. Pace of taper must be adjusted to patient's comfort level, following rough guidelines, but every patient comes with different set of challenges and opportunities. So there cannot be a uniform protocol. Too quick taper may stress out patient and they may relapse. When patient is ready, then following is rough guidelines. If patient is taking 32 milligram of buprenorphine a day, then they can start cutting down 4 milligram every 2 weeks or 4 weeks. Once patient is down to 4 milligram a day, then it is way harder to taper off. Go down to 2 milligram a day for a month, then 2 milligram every other day for a month, then 2 milligram when needed. Keep increasing the time period between subsequent doses. Once patient is on 2 milligram dose, I prefer to switch them to Zubsolv, which is available in zero point 0.7 milligram and it is easier to taper off patient. I also add clonidine as needed to treatment regimen to help with withdrawal symptoms. Physician must be very careful while patient is lowering dose. Going down too fast may lead to relapse and waste of several years of effort, and you have to start all over. After taper off. After patient is tapered off from buprenorphine, I recommend to stay on naltrexone, which is an opioid blocker, for at least 1 year. This may help you staying sober. But if patient has no cravings or can control cravings, then they can wait to be put on naltrexone. If they start having cravings, then they can be put on this medication. Once a patient is tapered off from buprenorphine, they must guard themselves against slipping back for the rest of their lives. What do you do with money you save being sober? I know patients who have been doing followings from money they save from being sober. Some of them put money in an investment bank account for retirement. Some put money in a college saving plan for a child in their lives or not in their life. Some I know have bought an automobile or a house. It will be rewarding to help others in similar situation where you were several years ago. It is important to take care of people whom we know, but there are always people who take care of ones they never knew or never met.